on shoulder pathology in sport and exercise medicine. I'm Dr. Kevin Assam, and I'll be leading you through this review. This slide contains a few of the conditions that we will be covering. Those in the bold font, unfortunately, will not be covered as part of this review. The format of this presentation is going to be similar to what you see on this first slide on rotator cuff tears. We will start with a look at the mechanism of injury typically associated with the condition. We'll talk about differential diagnoses, what to expect on exam or in history. We'll look at investigations that may be pertinent to the condition, and then finally we'll talk to management options. So we'll start with look at rotator cuff tears. Rotator cuff tears can be degenerative in nature or traumatic. It can be caused by overuse, by poor shoulder mechanics, or by advancing age. The differential for rotator cuff tears can be quite broad. Things to consider would be rotator cuff tendinopathy, cervicogenic issues with radiculopathy, may mimic biceps tendon pathology, may mimic labral pathology. Glenohumeral or AC arthropathy can also again the differential for rotator cuff tears, especially in non-acute traumatic cases. On exam, most of the time you'll see patients presenting with pain or weakness, with either range of movement or with resisted motions involving the rotator cuff tendons that are involved. In terms of specific testing for rotator cuff pathology, a lot of research has shown that it's very difficult to localize the pathology to a specific tendon based on a specific test. And so, for example, classically you may think of MTCAN as being fairly specific for supraspinatus pathology or liftoff for subscap, etc. We can't really confidently isolate each tendon pathology to a specific test. Nonetheless, those tests are helpful for us in terms of trying to reproduce the patient's pain or symptoms and can guide our approach to management going forward. In terms of investigations when it comes to rotator cuff tears, typically an ultrasound is the cheapest and easiest modality to obtain, and it gives us pretty good information, especially in the hands of an experienced MSK ultrasound technician. You may consider an X-ray if there's concern about concomitant osteoarthritis, either the AC joint or in the glenohumeral joint. Sometimes an MRI may be warranted to further characterize any findings that you may find in ultrasound regarding the tear, especially if it's going to help with surgical planning and management. And then finally, in terms of management for rotator cuff tears, it can be quite dependent on a few factors. The age of the patient. So, for example, older patients who are fairly sedentary or don't require a lot of overhead motion strength may not necessarily need repairs for even full thickness large tears. The type of the tear can also have a factor if it's a traumatic tear or degenerative tear in an older patient. Again, in terms of the tear characteristics itself, so the size, the depth, whether it's been retraction of the tendon fibers or atrophy, muscle atrophy, or fatty atrophy specifically, are all factors that can influence the treatment approach. I would say that generally physiotherapy is the first line for most tears, even large tears in younger patients, because there's always a benefit from addressing the symptoms and improving mechanics as best as possible. Certainly I'll consider surgical referral for acute, traumatic, large tears, full thickness tears specifically, especially in younger patients, in overhead athletes or overhead workers. I think those are patients that would benefit from a surgical consultation to discuss further treatment options. Also, if you have a younger patient with multiple tears, for example, you have supraspinatus, subscap, infraspinatus tears, those patients are more likely to have issues with shoulder stability and mechanical issues that may lead to arthritis earlier in the joint. And so for those reasons, you may want to consider surgical management as well. Next, we'll talk about rotator cuff tendinopathy, which is somewhat related to the previous slide. Rotator cuff tendinopathy, essentially, you can think of it as degeneration of the tendon, and more specifically, it's a condition of disorganized collagen matrix that leads to tendon weakness. Again, similar to the tears, tendinopathy can be due to overuse, poor mechanics, including impingement and advancing age, just due to the natural wear and tear on the body as we age, especially in people who have heavy demand in terms of their arm use, whether for work or for sport. Differential diagnosis here again is quite broad. It could be a tear, it could be cervicogenic in nature, essentially fairly similar to those you would find in the rotator cuff tear slide previously. Exam findings can be similar to those of the tear. Tenderness over the tendon, you may find on exam. You may have a positive painful arc, which is typically been mentioned to be between 60 and 120 degrees. You may find pain at the end ranges of movement, and your impingement test may be positive. One way people will try to decipher between a tear and tendinopathy would be potentially weakness, a significant weakness in the context of a tear, but in a patient with tendinopathy with a lot of pain, they may also have findings of weakness that may be a result of painful inhibition. So it's not essentially useful necessarily to rule out a tear just because of lack of weakness, or to rule in a tear for the same reasons. In terms of your investigations, similarly, ultrasound is probably best to assess the tendon in this case. You can consider getting x-rays if you're worried about other osteoarthritic features in the shoulder joint. The main goal of treatment for rotator cuff tendinopathy is to improve function and decrease patient's pain, which is typically achieved through physiotherapy. You may consider subacromial subdeltoid bursal injections if there's findings of impingement with concomitant bursitis. We will talk a bit more about calcific tendinopathy specifically in another one of the slides, so I'll skip the last point about barbotage or shockwave therapy for now. So we'll move on and talk a bit about calcific tendinopathy here. It's a condition that is somewhat poorly understood in terms of the etiology of it. It typically affects older patients, typically in the ages of 40 to 60, and essentially have pain due to calcific deposition in and around the rotator cuff tendon. The theory behind why this happens is that there is essentially degenerative change in the tendon, which leads to metaplastic transformation of tenocytes to chondrocytes, leading to tendon calcification. There are multiple phases proposed to be involved, and the most common tendon affected is the supraspinatus, followed by the infraspinatus and rarely the subscap. Gardner and Simmons came up with this classification system to essentially look at the three phases of calcific tendinopathy. The first phase is formative, and they suggest that in this instances, calcification is sharply outlined and dense. And in the second phase is kind of the stable form of the calcification, where you may find that a calcification is sharply outlined, maybe inhomogeneous or homogeneous, and there's usually no clear defined border to the calcification. And then in the final phase is kind of the resorptive phase, where the calcification is a bit more cloudy and a bit more translucent. So the pictures on the bottom there depict essentially two of the phases that you may see. In the one on the left-hand side of the screen, you kind of see more of the formative phase, where there's dense and sharply outlined calcification. And in the right-hand side, you're kind of more towards that second to third phase, where things are a bit more cloudy, up parts of the calcification and a bit more inhomogeneous. In terms of differential for calcific tendinopathy, you may consider just simply rotator cuff tendinopathy, or may present with a sign of an impingement syndrome. On examination, patients will present typically with spontaneous atraumatic pain and stiffness. The pain is typically worse during the resorptive phase, and patients typically in this phase may report sudden change in terms of intensity of pain, without any clear inciting incident. They may report catching symptoms with the movement of the arm, for example, decreased active range of movement, which is pain inhibited, and you may find positive impingement tests, such as the Hawkinson-Mears signs. X-rays and ultrasound are best in terms of imaging the pathology. The ultrasound can essentially tell you if there's other rotator cuff pathology involved, but obviously clinical correlation is required to decide on what the findings show and if they're relevant. X-rays usually will show calcifications quite clearly as well, especially in the first and second phases. Management of this is similar to other simple rotator cuff tendinopathy in terms of therapy. Anti-inflammatory medications can help. It's controversial as to whether or not steroid injections are efficacious, and if they are, then what is the duration of effect? That is not clearly well known, but certainly something that may be considered. Shockwave therapy, the literature seems to be helpful for calcific tendinopathy, perhaps best in the first and second phases. And ultrasound-guided barbotage or lavage procedures have been shown to be quite helpful. Again, this is debatable whether this is best in a particular phase of the condition, but certainly in my clinical practice, I find that it can be quite helpful. Depending on where you practice, there may be somewhat, especially if you send in the patient to see a radiologist for the procedure, there may be some restrictions as to when to do this procedure, so you may want to kind of clarify that. And then finally, you can look at surgical decompression, which is very rarely necessary, but that may be an option, arthroscopically, to go in and debride the calcification from around the tendon if necessary.